Sounds good. Hello, good afternoon, everyone. Thanks for being here. So just wanted to take a minute. So today is Think a Resident Day. So just wanted to take a second to thank you all for all that you do. We really appreciate you. The lunch today was provided by the hospital as a thanks to you. I know it's just another small way of us showing our appreciation. So hope you enjoy that. Today, we have Dr. Surescu. So he is one of our esteemed cardiology colleagues in the heart failure department. So he's going to talk to us more about SGLT2s, but to tell you a little bit more about Dr. Surescu. So he received his medical degree from Carol de Villa University of Medicine and Pharmacy in Bucharest in Romania, completed residency at Beth Israel Hospital, and his clinical cardiology fellowship at Emory, as well as completed a research fellowship with us. We have been fortunate enough to have him stay on with us afterwards as both a clinical academic faculty in cardiology and for our internal medicine program. So if you don't know, Dr. Surescu has a series on YouTube that is a great resource for us and his patients. So I would highly recommend. So I could probably keep talking about Dr. Surescu, but I'll just let him take the podium and talk to us more.
Thank you, Lakshmi. And it's always an honor to be here. And really, I got to tell you, one of the reasons why I do what I do is because I enjoy working with you guys. And I'm really very grateful for being able to enjoy, you guys teaching you. You are working hard. Once upon a time, I used to be in your shoes, and I can tell you, at least as far as I'm concerned, everything you do is always very appreciated for us and for our patients, and allow me the opportunity to do what I do. So I thought we were going to talk about a new class of drugs that actually have been developed over the past 10 years that really have become a therapeutic drug for actually cardiologists, also internists and nephrologists. So I entitled A Tale of a Salt and Sugar, and I will try to make a point that really in our body, the salt and particularly sodium, it's always processed with glucose. And I think we stumble upon a mechanism here that actually we got it right for the wrong reason. And I'm going to explain a little more over the next 45 minutes or so. But bottom line, we're going to discuss about how SGLT2 inhibitors actually may impact on our cardiovascular disease, the mechanisms, and some of them we know, some of them we're not sure. They're still at the hypothesis level, but I think whatever I selected here is something that I can hypothesize is going to be with us for the next 30 years or so. We're going to review the clinical trials of cardiovascular and renal outcomes with these medicines, and particularly everybody knows heart failure is important to me. We're going to also review the clinical trials and the updated guidelines in patients with heart failure related to these medicines. Of course, I couldn't start without reviewing first, what do we have so far? And I'm not going to go into details of 30 years worth of research in diabetes and cardiovascular outcomes. Suffice to say, 3 really drugs have been shown so far out of this that improve cardiovascular outcomes and renal outcomes. Metformin is actually, turns out it's superior to insulin, also found in ureas. This is all data, and there are still colleagues among us that don't realize the insulin is never shown in type 2 diabetes to actually improve cardiovascular outcomes. As a matter of fact, we might have some evidence that may be deleterious. GLP-1 receptor agonists like liraglutide, semaglutide, dulaglutide, they have some mild effect, but really SGLT2 inhibitors have come now to forefront of improving outcome. And this is an old study, but also unfortunately the only study. It's called the Takehome study, where patients who had acute myocardial infarction were randomized to a regimen that was based on insulin, metformin, or sulfonylureas. They were followed for almost 2 years. And to everybody's surprise, metformin actually, if there's anything, improved mortality, often due to cancer-related conditions. and overall death, but also borderline improved cardiovascular death. Unfortunately, insulin regimens, that means continue to the need of the patient take insulin even as outpatient, was associated with twofold higher risk of actually new myocardial infarctions. We don't talk much about that, but that's extremely important to know that yes, insulin, if you need it for sugar 400, yeah, you need to get that sugar down so patient doesn't go into hypoglycemic crisis. But long term, we got to do something better to actually reduce that need for insulin, because by itself won't help us. Then, of course, most recently, a plethora of studies with GLP-1 receptor agonists and SGLT2 inhibitors showed actually improvement, mild in the case of GLP-1 receptor agonist, and more significant actually with the SGLT2 inhibitor. And of course, I'm going to discuss the rest of the time, mostly the SGLT2 inhibitors. But basically, right now, what we have is thumbs up for metformin. The role of metformin probably is going to be soon challenged. Soon we have currently ongoing clinical trials with SGLT2 inhibitors versus metformin as a primary treatment for diabetes type 2, and we shall see, hopefully look forward to results for that. GLP-1 receptor antagonist and SGLT2 inhibitors. Now, everybody laughs at metformin, but it's still a $4 drug. The others are anyway between $600 and $800 a month. So there's no point of having these great drugs if there is diabetes and resistance, financial resistance to it, or I call the diabetes of the cardiovascular drugs. Hopefully with time that may change. So let's talk about the potential mechanisms, how SGLT2 inhibitors may help us. And we're going to talk first of cardiac effects, then we're going to talk about renal effects. And then, at the first side, basically SGLT2, they block the reabsorption of sodium and glucose in the proximal tubule. You get about a total of 50 to 75 grams of sugar, glucose excretion daily out of that, which, think about it, it gets rid of 50 to 75 grams of glucose that you put in your mouth. And that, of course, will, it doesn't affect the SGLT1, which I'm going to show you some data. It turns out when you block SGLT2, especially in diabetic patient, SGLT1 actually gets upregulated, compensatory. So it's kind of difficult to really explain all the cardiovascular beneficial effects through just hemodynamic effects and, just losing some, basically a mild diuretic effect if there's anything. And I'll show you some data there. And actually the main hypothesis, at least by cardiologists, is that, hold on a second, there's got to be some effect on cardiac remodeling and possible neurohormone activation, which we know is absolutely essential for heart failure progression. And indeed, this study that was published a few years back looked at 10 patients with left ventricular hypertrophy. They put them for 3 months on empaglifozin, and then they measure, sure, this is echo-based study. 3 months later, diastolic dysfunction has improved, but also the left ventricular hypertrophy. So clear, there are some, although there are no receptors for SGLT2 that we know in the heart, something is going on there. There's more than just urinary excretion of sodium and glucose. And I think in order to solve this puzzle, I'm going to have to take you back for about 30 years. Let's assume this patient that we see today in the hospital, in the clinic, who's got the usual diabetes type 2, obesity, cardiovascular disease, possible kidney disease. We met this patient about 30 years ago. And the way it works, I'm going to hypothesize to you that really, remember, no matter how hard we're looking, we don't find a genetic abnormality in type 2 diabetics for more than 5, at most 10%. So one can infer that over 90% are actually not genetically determined. And what it is, we all eat the same processed, ultra-processed food, which is rich in saturated fat, fructose, and it's extremely low in fiber, which is designed to actually prevent us from absorbing that. And when you combine all that over 30 years, really liver is the first sensor, the first station from the gut. It senses that we have gluten in here, and it needs to start storing. Basically, fructose is not even metabolized by any other tissue in the body except the liver, and believe it or not, the testis is actually, fructose is the only food for sperm cells. So once liver senses that, actually it knows it needs to store. It will store only in itself and in the adipose tissue. And then it sends insulin resistance signals to the rest of the organs, which know they cannot store: muscles, heart, brain, kidney, you name it. So this is a cycle that keeps perpetuating over 20, 30 years. And basically the rich get richer in terms of fat in these organs, and the poor get poorer. There'll be more and more starving. I'm going to show you some data of that actually, while our adipose tissue and liver are enriched in fat, actually most of the rest of the organs, particularly essential ones, heart and kidney, are actually starving. So basically, I'll summarize to you that this all started with a Western diet and basically fatty liver. All right, and let me show you a little bit of data here. This is a small study with 100 patients. Everybody at VA who came got a heart cath had documented single 2-vessel, 3-vessel disease. If you actually look for fatty liver, if you have single vessel disease in this study, you got about 85% chance of having fatty liver, and it goes all the way up to 100% if you have that. So this is just a very strong link between fatty liver and cardiovascular disease in this patient. Guess what? Currently in our general population, you have about 25% of us having fatty liver. So I'm not going to do the math here, but you can imagine how many of us will have it if we were to get tested. Unfortunately, as you know, the testing, the absolute gold standard will be MRI. It's fancy testing. There are some other ways, but they're more or less sensitive than that. Then I mentioned if you have coronary disease, single vessel, 86%, we can go up to 70% if you have type 2 diabetes. Pre-diabetes, which is an interesting term, is like you're almost pregnant, but you're not yet. I don't think we could apply that for any other condition. But then if the patients undergo bariatric surgery, it's all the way up to 95%. So very tight correlation. And like our Dr. Larry Sperling, who is the chief of our cardiology preventive clinic at Emory, mentioned it, and there are two fascinating review articles that he wrote. Really, the intersection between heart and liver is an important intersection to be aware of. I will actually summarize to you that the way all this starts, this combination of excessive fructose, sodium, low fiber, which is supposed to protect us from doing that. American Heart Association guidelines says we need to have at least 30 grams of fiber. Do you know how many salads you're supposed to eat to get there? You will have to probably eat a good 3 to 4 pounds of salad every day. So obviously that's what we're supposed to have. Obviously nobody can do it, at least not in current way how we're eating. And basically ultra processed food leads to all these conditions. For some reason, if you live long enough, we are going to have, all of us, every single condition. So I have patients who present to me in their 50s with just heart attack or heart failure. If they get to live, I diagnose usually 2 or 3 cancers 10 to 15 years later. And the same eventually with dementia. And really, I summarize to you, this starts with fatty liver. All right. And basically what feeds me also destroys me, which is an old Latin dicton here. So I would like for you to see a process as this gluttony affects first the liver, then the heart, then the kidney, and of course, brain is part of that. We start with fatty liver. We get the usual, initially just healthy obesity, then eventually becomes morbid obesity, what we define by insulin resistance. Of course, we kind of not test for that. We just see somebody's overweight and that's it. Then one way or another leads to heart failure. Initially presents as heart failure with preserved ejection fraction. Eventually, after we get the other cardiovascular conditions associated with it, this kind of diet, eventually most of the patients will also acquire HFrEF, heart failure with reduced ejection fraction. And last but not least, late in the disease, we start to have kidney disease. Now, this is, once you have kidney disease, we know is advanced. And the majority of clinical trials I'm going to present to you, it's about advanced disease. And maybe I'm going to submit to you that if we can do this, you have this impact even in advanced disease. We can have a way higher impact, even earlier disease, by working not just with proper drugs, but also with lifestyle changes. So this is the vision that I'm going to set forward for you to think about it. And you'll say, well, this is not a reality. Well, I'm not making this up. Right now, 10 to 20%, 1 out of our 5 teenagers, aged 10 to 20, have this, at least obesity and unhealthy obesity. I'm talking about insulin-resistant dyslipidemia, every marker that if we were to meet an adult, we say this is bad. And the overall morbid obesity at the adult level has reached 40 to 50%. Obviously, we're not unique. Almost in every country in the whole world, this is occurring. So this is the true epidemic here. And I'm here, everybody wants to know, okay, what's causing all this? If I were to name one arch enemy here that actually has been proven, is fructose. And very few people are actually familiar with it. It's not really the glucose that kills us from the diet, it's actually the fructose. Why? Because fructose blocks our organs from using the glucose. We don't have receptors, but in the liver. As soon as liver sees the fructose, it thinks this is alcohol. It's unnecessary calorie. We can get fatty liver only 2 ways that has been demonstrated so far. Either alcohol, which is becoming now number 2 in terms of cause of NASH, but really the number 1 is fructose. This has been heavily and has been very well demonstrated by Dr. Lustig. Is a lot of the principles that I'm teaching you now is actually from his own research. And basically fructose causes fatty liver and de novo triglyceride synthesis. Everybody thinks we get fat if we eat fat. No, we get fat if we eat glucose or fructose. Those are the actual biochemical pathways in the liver. If we eat fat, that fat goes into soluble lipoproteins, then go into our arteries. They don't go into fat. They try to, but they don't make it. So that's important to know that. So if you just feed fructose to an animal or a human, turns out we can just recapitulate everything we know is bad with risk factors for cardiovascular disease. Dyslipidemia with a low HDL, high triglyceride, high cholesterol diet. I call this a diabetic lipid profile. I have patients who come to me, they look for risk factors. Of course, they come with a calcium score because now everybody can get that. And when they are 30, 40, 50 years old, oh, my calcium score is high, but nobody bothers to check their lipid profile. I check the lipid profile and say, well, I don't have anybody in the family. This is my lipid profile. And I don't have diabetes. Indeed, hemoglobin A1C is normal. As far as I'm concerned, liver is already seeing diabetes. That's a marker for insulin resistance. You also get elevated uric acid. Why? Fructose, it's metabolized either towards new triglycerides or towards uric acid, all right? And of course, we eat, the more sodas we drink, the more we eat. It never stops your hypothalamus to keep making you eat. And so actually many years ago, about 10 years ago, I had a basic research lab, and I really wanted to have an animal model. Here is a mouse murine model of metabolic syndrome and just study what happens in the heart to really phenotype this kind of phenotype. And I associated with Dr. Anania back then. He's still an expert at NIH now in fatty liver and NASH. And he was putting these mice at their teenager years, which would be 4 weeks old for a mouse, onto this Alios diet, which is basically equivalent of a burger a day and a soda a day, meaning fructose 2% in there. And then he says, well, you look in the heart, I'll look in the liver. And we did. And to my surprise, these are teenager mice who within 6 to 8 weeks, they start to have actually reduced ejection fracture. And by 16 weeks, they develop dilated cardiomyopathy with an ejection fracture of 35%. And that's all they had. Mice are omnivores like us, but if you ask them, they prefer to stay healthy, actually, vegetarian diet. But we gave them that, then that's what we convert them. So there must be some sensitive phenotype here. But then when we look at the heart, to my surprise, within 4 to 6 weeks, the heart was already insulin resistant. All right. And that coincided actually, eventually when we followed them at the molecular level and we did all kinds of RNA and protein analysis, turns out I can reproduce in 16 weeks what happens in a human over 30 years and create actually advanced heart failure with a starving fetal heart phenotype, just like you were otherwise with coronary disease or any other etiology of heart failure. So basically, we convert a happy, healthy heart into a starving heart that changes the phenotype to a fetal phenotype. And you'll say, well, what is that? Here's what it is. A fetal heart phenotype is adapted to grow very fast, billion times in a condition of low oxygen and no fatty acids, a low glucose. That's it. Does that under angiotensin II. But it's actually a cardiomyopathic heart. The ejection fraction for a fetal heart is 30%. And he can afford that because he only needs, the afterload is about, a systolic pressure of 30 millimeters mercury. Now, if you take this heart and you put it in an adult heart where the afterload is 5 times higher, it's already cardiomyopathy. So you really don't want to have fetal phenotype in an adult heart where it's way maladaptive for this kind of thing. So if then we said, well, what about the fatty liver? And of course, fatty liver in these mice occur as early as 6 to 8 weeks. And it was coincidental with development of insulin resistance. So we actually gave them back then. Dr. Anani actually was one of the first to demonstrate that liraglutide, the GLP-1 receptor antagonist, we put them on this and then we followed them. And indeed, it helped with the fatty liver. It helped with insulin resistance and glucose intolerance. But also, when I look in the heart, it reversed the left ventricular hypertrophy. So this suggests that really it's not just the heart, it's actually everything starts with the liver. And we have now equivalent data actually for the SGLT2 inhibitors. So of course, this is basic research and it still needs to be proved at the human level, but we have some evidence, at least for fatty liver improvement in for GLP-1 receptor antagonists. We still don't have wide range, scale SGLT2 inhibitors in human clinical trials for fatty liver. Bottom line is treating fatty liver, at least in animal studies, shows they can reverse cardiomyopathy associated with this. So now let's get back to the heart. Wait a minute. We don't have any SGLT2 receptor in the heart. How does that work? Well, there is no magic. It turns out the SGLT2 inhibitors that we know, empaglifozin in particular, they bind to another channel in the heart. And they're not as specific as we think. They bind also to the sodium hydrogen exchanger. Sodium hydrogen exchanger 1 in the heart has a very fascinating role. It's actually present in heart, liver, and kidney, and in the gut. And basically, if you were to see what it does, if you have any kind of myocardial injury, if the cells perceive that there is a lack of ATP production, we are deficient in ATP, immediately you switch your mitochondria from ATP production to acid production. Once we have lactic acidosis, that excessive hydrogen needs to be excreted, otherwise the cell is going to die. And that's what this sodium hydrogen exchanger does, okay? And when you do that, the price you pay, you get sodium overload in the cell. Now, that's not good either because then the cell is going to start to blow up and it could die. So the way we compensate for that, we get a sodium calcium exchanger to get rid of the sodium by putting calcium inside the cell. Now, once we have chronic elevation of cytoplasmic calcium, that triggers actually is part of how all these angiotensin II catecholamines drive a change from a healthy adult cardiac myocyte phenotype to a fetal phenotype, which allow us to hibernate and the cell doesn't die, but it's maladapted for long-term sustained impact. So now we have a SGLT2 inhibitor that doesn't just bind the sodium glucose transport, but actually binds to the sodium hydrogen exchanger. And it's possible that basically that reverses this increased tendency of sodium and calcium increase inside the cell and may actually block the pathophysiologic effects at the heart, kidney, and liver level. Now, this is basic science. It's been actually at the animal model. We know this is true, whether you're looking a ischemic or non-ischemic diabetic type 2 model in rats or mice. Dr. Ibora and his colleague had an amazing paper back in 2019 where they showed that giving empaglifozin in these animals actually prevents cardiac myocyte injury, a survival, and then they pretty much decipher all this pathway. There was actually downstream of sodium hydrogen exchanger 1. All right, so pretty much we have now data enough to hypothesize that a lot of these beneficial effects, at least in the heart, from our SGLT2 inhibitors are actually related to the ability of preventing cardiac myocyte apoptosis and hypertrophy, actually reducing resistance to leptin and insulin, prevents fibroblasts from being active and produce ongoing cardiac fibrosis. And of course, we know that it's good to decongest the heart and the kidney, but also allows the heart to be able to utilize again fatty acids and ketone bodies, which actually prefer substrate for the heart. Just one more piece of data to show that actually this sodium hydrogen exchanger is actually essential for least fatty liver. A study where they took these mice who are deficient in sodium hydrogen exchanger, their gene was knocked down for that, and they were put on this kind of type 2 diabetic diet. Turns out they have, it reverses their insulin resistance. They actually don't get fat. It really normalizes the mitochondrial metabolism of the liver, actually can utilize glucose as a substrate, and also reverses and prevents fatty liver. Okay, so bottom line is I'd like for you to take home this concept that while it's not completely proven in humans, we know for sure, we do have evidence that this the SGLT2 inhibitors bind to the human cardiac myocytes. There's no doubt about that. How much is this row of the effect, beneficial effects are because of this? We don't know that yet, but it's definitely something that at least in other basic science research studies have shown to be essential for actually the type 2 diabetes impact on heart failure and cardiovascular disease. So now that we're going to talk about the potential renal beneficial effects here. We talk about the heart, how it may work, binds to that sodium hydrogen exchanger that's essential. Let's see about the renal effects. Well, the story should be simple here, right? So as hypothesized, we got a drug that binds to the proximal tubule sodium glucose transport receptor 2, which is supposed to be in charge of 90% of our glucose reabsorption. Then you lose that 50, 75 grams of sugar a day. But what's fascinating, when you do that, it also has a positive beneficial effect. The excessive glucose delivery activates a uric acid co-transporter that actually excretes uric acid. So yes, this might be some form of mild diuretic, but it's opposite to the loop diuretics. It actually gets rid of uric acid, and that has been shown in humans, in patients with type 2 diabetes. There's also beneficial effect on renal circulation, particularly the glomerular filtration. Is once we have excessive sodium and glucose concomitant delivery to the kidney, actually that turns off the macula densa from activating angiotensin 2 and actually releases adenosine, which will then cause vasoconstriction of the afferent arterioles. Now, remember, a diabetic kidney, has a hyperfiltrating, the GFR is actually initially elevated from all the sugar. Actually, you want to reduce that hyperfiltration rate. So this normalizing the renal intraglomerular hemodynamics is extremely important outcome here. And at the end of the day, to their surprise, it turns out it also is able in diabetic patients to raise their erythropoietin, which we know this could have potential beneficial impact, at least on patients or heart failure. I mean, how many of them we have them on service? We find them with anemia, and I think that's important. Now, let's see. Well, so far the main hypothesis how this work beneficial effects in the kidney and heart failure is that they're just another diuretic. Let's see how that compares with the regular diuretic. Well, if you were to apply a loop diuretic or a thiazide to give it to a patient with heart failure, and we measure their actually absolute intravascular volume, interstitial volume sodium, all three go down. Obvious, everything is because you pull off sodium from the kidney. The water is gonna follow, but you also have your intravascular volume goes down. And we know what happens if you diurese with intravascular going down, that activates renin-angiotensin system. That's the price we pay for having to use a diuretic in patients with heart failure. But if you do the same with the SGLT2 inhibitors, that's not what we see. What we really see is actually the intravascular volume actually stays constant or is minimal change. It's the incidence of symptomatic hypotension in all these cardiovascular clinical trials is about 1%. It's extremely low. Doesn't mean it cannot happen, particularly if you concomitant use the diuretic. That's why sometimes we need to back off on those. But it's really is able to diurese or natriurease and glucurese without actually activating the renin-angiotensin. And that's what I'm proposing to you. And the big picture, though, what I'm submitting here is not just an immediate hemodynamic effect, reducing the afterload and preload. Really, the effects on blood pressure is maybe it drops 1 millimeter mercury. I doubt that explains the beneficial effects. The hemoglobin C drops by 0.5 to 1 if you really get lucky, but very minimal. doesn't cause hypoglycemia. So how is that happening on long term? Why do you get these tremendous beneficial effects on long term? And the way it works, I think, is again, it's affecting our arch enemies. Arch enemies in type 2 diabetes and heart failure are two: insulin and angiotensin 2. And all interact with each other. Once you activate, you have excessive sodium and glucose in the interstitium, in the kidney, in the heart, in the liver. That activates more insulin, but we're insulin resistant because it activates Ang2, and angiotensin 2 causes insulin resistance in a perpetuating cycle. So what this actually is SGLT2 inhibitors, because now they can block both of these outputs of both insulin and Ang2 by working on GL2 receptor 2, but also on sodium hydrogen exchanger. This is number 3 from the kidney. Number 1 is in the heart. Actually, it's like suddenly Ang2 and insulin are toothless. They can't do that. And that's the hypothesis that I'm submitting here. So basically, SGL2, sure, they decongest the kidney. Yes, there's some beneficial effect from that. But the key is here, they do it without activating the renal angiotensin system. And I'm going to explore, and for those who want to know more details, this is a hypothesis that submitted by Dr. Braunwald and Dr. Zelniker in a beautiful JACC review article. But basically, when you block both the sodium hydrogen co-transporter and the SGL2, you have excessive delivery of both sodium and glucose. So they are together. That's why I said this is a tale of salt and sugar. Our body does not see them separate. It sees them together, and that's how it's processed. Once you have this abundance of sodium and glucose in the urine, that turns off and calms down the macula densa, so it doesn't activate angiotensin. As a matter of fact, it activates the opposite, adenosine, to vasodilate the efferent arterioli and vasoconstrict the efferent. Actually, this kind of response has been very well documented in long-standing hypertension. When the blood pressure is too high, actually causes pressure diuresis by exactly this mechanism. And that's protective. That's why you have renal set point, okay? So these are the hemodynamic effects, but there is more, okay? And what is more is this, that when you look at long-term effects, and if you try to actually block both SGLT2 and sodium hydrogen exchanger, and at least in diabetic rat model, it turns out that use of dapaglifozin in these diabetic rats prevents totally the angiotensin activation in the kidney, but not systemic. So if we just look systemic, we're not going to see it. But if you were to measure angiotensinogen or aldosterone in the urine, actually you're going to see the beneficial effects. That's number 1. So I'll show a piece of data that it does cut off the angiotensin response in the kidney, at least in animal models. Number 2, long-term, reduces the inflammation induced by type 2 diabetes. It reduces the glomerular damage and renal fibrosis, and this is the quantified version of that. So I'm going to basically hypothesize to you here that actually the real long-term beneficial effects at the kidney level, just at the heart, while obvious there are some hemodynamics effects, there's not, and they manifest as early as 4 weeks. The real long-term effects are actually probably more likely through the blockade of insulin and angiotensin effects in the kidney long-term by reducing inflammation and fibrosis. So if I were to sum up this little story that I told you, the way SGL2 work inhibitors on long-term, if we start with processed food, you get fatty liver, you get eventually insulin resistant and diabetic heart, which switch to fetal phenotype, that's maladaptive, angiotensin activation in each of these organs. Eventually, late stage, you got a kidney. So this is the order: fatty liver, diabetes, when we start to have problem with cardiovascular disease in the heart, and then late stage, when we start to be in the hospital and dying, kidney involvement. All right. And of course, SGL2 somehow are able to intercept this, all 3, through blocking not just the sodium glucose transporter 2, but also sodium hydrogen exchanger. All right. So now that we got that, let's get to our bread and butter here. Let's review the clinical trials for cardiovascular disease. And of course, I'm going to first remind you that the pathophysiology of end organ damage in diabetes starts way before we actually define diabetes. We define diabetes once the glucose goes up. Okay, that's here. But if you go back, most of the macrovascular disease, that means true cardiovascular disease, coronary disease, neuropathy, starts actually at the insulin resistant level before we actually tell somebody that they have diabetes. As a matter of fact, we tell them they have pre-diabetes. I am going to submit to you that we're not going to ever win against this until we change that. To me, pre-diabetes is like you're telling them you're almost pregnant, but you're not there yet. So you act accordingly. I think we really need to switch the gears into treating diabetes, diagnose first insulin resistance, have actually a proper test for that, and then start to treat this patient as diabetes at the insulin resistance level if we want to prevent cardiovascular outcomes and neuropathy. So if you were to look at that, and I told you kidney comes late in the disease, then I can instead of going over each and every trial that was published about this, I'm just put them here together. There are 4. Is declared TIMI 58, basically Canvas and Empareg, which are each of them the 3 drugs that we know: dapaglifozin, canaglifozin, empaglifozin. And more or less, they look like similar. They took patients with risk factors for cardiovascular disease already with cardiovascular disease, like a prior heart attack, with a certain level of degree of kidney dysfunction. All right. And then they randomized them to the drug or placebo, and they're surprised it significantly impacted all MACE and all combined endpoint of MACE and cardiovascular mortality. So that's all good. But if you were to re-stratify them by GFR, then I can show you that these patients had slightly different prognosis to begin with. So you can see, according to GFR, the declared TIMI trial, dapaglifozin, they were actually earlier in their condition than the other one, the Empareg and Canvas. And really the most significant and the highest risk patients were actually the patients in Credence trial. Just for those who don't know, Credence trial is actually a trial designed for nephrologists, not for cardiologists. But all patients with diabetes and advanced CKD, GFR anywhere between 30 to 90, but they had clinical macroalbuminuria. So these are patients who are about to get into nephrotic range of their proteinuria. And they had a baseline GFR 56. So then we randomized them, and look what it showed in terms of the outcome here. The more advanced was your kidney disease, the more benefit from these drugs. You see how they just line up just based on their baseline GFR. Okay, it shows you it's good for prevention in early disease, it's good for advanced disease. And the same whether you look at MACE, all right, or if you look at combination of cardiovascular death and heart failure. And of course, the biggest impact was actually in heart failure related admissions. And obviously, this was a secondary endpoint. Nobody was expecting that. And the biggest impact of preventing heart failure hospitalization was in those who had actually a worse GFR. So really, a lot of heart failure prevention was pure related to actually working on the kidney here. Okay, so that's the take-home message there. Now, for those who actually start to use it in the practice, they will see, just like we have with ACE inhibitors and ARNIs, the combination of valsartan and sacubitril, you have an initial drop in GFR in the first 2 to 3 months when you stop. Okay, don't panic about that. If we follow long-term, their GFR actually stabilizes and gets much better compared to those who don't. So that's important. Why? Probably because initially that hemodynamic effect that I was telling you about actually dropped your GFR because it dropped the intraglomerular filtration pressure by vasoconstricting the afferent artery and vasodilating the afferent one. Okay, and that's important. So, and now we have a whole range of clinical trials. You don't need to load your memory with this. That's my job. What you need to know is, I'm going to talk this, that there's one of them who actually didn't reach statistical significance, even it's called ertuglifozin, which probably is not going to get approved here. It's not too clear why. I suspect that I don't see the GFR that I expect. Maybe the patients that were enrolled were not as sick as the others, okay? But everything else was quite positive. And I'm going to talk a little more about a unique one that hasn't gotten approval yet. It's called sotaglifozin, and I will explain to you why. But as of now, the American Diabetic Association guideline says, if you have diabetes type 2, first line is metformin. which that role may be soon challenged with new trials compare against SGLT2 inhibitors. But if you have any version of cardiovascular disease, atherosclerotic disease, then you can feel free to add the second agent, either GLP-1 receptor agonist or SGLT2 inhibitors. You have heart failure, second agent is SGLT2 inhibitors. You have renal disease, second agent is SGLT2 inhibitors. So I'm going to switch now, and I'm going to talk about diabetes and impact on cardiovascular disease of these agents. Let's talk about how about heart failure per se, independent of diabetes, okay? And based on the fact that in those initial trials, heart failure was the main way how it improved cardiovascular and MACE. They designed a trial where dapaglifozin was used in everybody with the level ejection fraction less than 40% on top of excellent medical therapy. I mean, everybody was at the proper dose, over 90% at the proper dose and the proper regimen of either ARNIs or ACE inhibitor, beta blockers, and spironolactone. Okay, or mineral receptor antagonist. And then when you look at the primary outcomes, there was a tremendous impact, about 25% reduction, either cardiovascular death and then combined with hospitalization, and or even independent, just cardiovascular death or mortality. And really most of beneficial effects was from hospitalization. Just to have an idea, we always use, in order to realize the impact, how much does this bring us? We look at necessary number to treat. Well, the necessary number to treat is about 20 here, all right, for the combined endpoint. To put this in perspective, ACE inhibitors like lisinopril in the SOLVE trial is about 40 to 1. So of course, the lower the number, the more beneficial to apply it on a large scale. And you can go up to 50 if it's just all-cause mortality, which is a big deal compared to others. So right now, if I were to put all these patients on all the systolic heart failure medicines we have, all right, if they're not on medicines, all right, they have a mortality at 24 months close to 35%. If we start to add them all up, including the SGLT2 inhibitor, then we drop that by almost 3/4, 73%. Or you can explain to the patient, this will buy you 6.3 years of life in average. We can get you to tolerate both obvious from the side effects perspective, but also financial perspective, all these medicines. So it's a big deal. And then of course, since then we had also the empaglifozin. Empaglifozin is another SGLT2 inhibitor that's been approved now. It pretty much on the Emperor reduced trial, it showed similar data, although not as potent, as robust as dapaglifozin, but you can in a combined meta-analysis pretty much shows the same data and altogether about 25% relative risk reduction. And once again, how is that related to? Improvement in the kidney perfusion and kidney function long term. And that's the key here. All right, remember that kidney. And basically, this makes everybody happy. This makes the cardiologist happy. It makes the nephrologist happy. And here, I just want to step back a little bit and tell you there's more to the story, okay? When you block the SGLT2 in the kidney, although normally in anybody who's healthy, 90% of that glucose absorption is through SGLT2, it turns out that the SGLT2 goes up, especially in patients who are diabetic. So there's a compensatory changes, although that was supposed to be a higher affinity, lower output when the receptors go up and you have more of those channels, they can make up for that too. As a matter of fact, Dr. DeFronzo, who is a famous diabetologist at University of Texas in Houston, he actually discovered and published in JCI over 20 years ago, the SGLT2 inhibitors. Stated that you guys should design a drug that blocks both, not just one. And guess what? Now we have one of those drugs. It's called sotaglifozin. And probably this is more for the future. Or I can tell we have two studies that were designed with this. One is the SCORE trial that it's a similar trial, just like the TIMI 53 trial. And basically, it's a dual SGLT2 and SGLT2 inhibitor. Patients randomized to 400 milligrams of sotaglifozin. Remember, this blocks the SGLT2 receptor not only in the heart and the kidney and or in the liver, but also in the gut. So it blocks potentially even glucose absorption there. You would expect side effects, some diarrhea, which indeed it happened about 6% of these patients, but very few had to discontinue because of that. But short of that, in patients with diabetes and acute decompensated heart failure, that means all comers, whether it's HFpEF or HFrEF, who had a recent admission in the hospital for that, as soon as they were discharged, you're placed on this medicine. And the combined endpoint of cardiovascular death and MACE was actually dramatically improved, especially heart failure readmission. But it didn't reach statistical significance as an independent improvement in cardiovascular-related death or overall mortality. And I actually think the reason is because it's probably the shortest study we had. They had to stop after 18 months because they ran out of studies, a small company. I'm sorry, they ran out of money. So it's too bad, but I think that they submitted actually to approve the drug to FDA. We'll see in December what comes back. But I think something to watch for future, because at least according to the expert, this can predict potentially even better outcome on long term. And then more recently, we have we studied this effect of SGLT2 inhibitors, not just in HFrEF, that means ejection fraction less than 40%, but also in HFpEF, which it's very fascinating in this heart failure with preserved ejection fraction trial. It was considered preserved ejection fraction, 11 ejection fraction is more than 40%, which is actually the first kind of trial like that. So you have this mid-range ejection fraction of 40 to 50% that before they were not actually enrolled in these HFpEF trials. And the combined actual endpoint between hospitalization and death was improved. It didn't reach statistical significance for the death itself, but considering that only 20% of all admissions were from heart failure. That means 80% of this patient came in the hospital again for other reasons. And from those 20%, we were able to actually improve hospitalization by 25%. That is a tremendous, it's a strong signal there that yes, for the future, there is some role for these drugs into HFpEF2. What's fascinating is we don't know exactly whether that's because of turns out most of the beneficial effects were exactly these mid-range patients between 40 and 50. So it's something to think about, where these patients, the one who are gonna move to become HFrEF and they would have benefited anyway. We know that the effect kind of goes away if the ejection fraction is higher than 60, 65. So there's still a lot to be tested there, but it shows you that there is a strong signal that these are beneficial. And this effect actually started as early as 4 weeks. So what we have so far about SGLT2 inhibitors, they're good. You have diabetes and just diabetes type 2. They help you lose actually about, in average, about 10 to 12 pounds, lower the glucose and helps a little bit with the blood pressure. They prevent cardiovascular outcomes in terms of MACE. They help in patients with reduced ejection fraction. They help in patients with progressive kidney disease and cardiovascular death. And we definitely helps in patients with heart failure with preserved ejection fraction, as long as the ejection fraction is more than 40%. As a matter of fact, based on that, FDA just approved it yesterday. They can be used in any patients with the ejection fraction all the way up to 60%. So there will be more to come about that. But just to have an idea, this is obviously not the only drug that we have proven to actually have impact on hospitalization in heart failure in HFpEF. The others, candesartan and ARNIs, which is entresto-like drug, have shown to do that too, but only 10-15%. This is about 25 to close to 30%. So it's much more pronounced effect. So the same Dr. DeFranco who really invented this, he's the endocrinologist and diabetes expert. He says, attention, these drugs are for cardiologists. Don't be afraid to use them. I would actually submit to you that after the data we have, they are for nephrologists, but also for the internists, because the internist is the one who sees these patients at early stages when they develop morbid obesity, and eventually they progress from fatty liver to cardiac disease and renal failure. All right. And of course, let me give you a couple of tips how to use it, what to expect. I mean, obviously, there are new drugs. We need to get familiar with them. So here's what you expect. You expect in terms of side effects, really we have 1 to 2% increased incidence of genital, particularly fungal infections. I would say probably those occur those who have poorly controlled diabetes. So if the sugar is 400, I wouldn't necessarily start them right away. I would probably try to get their diabetes a little better controlled, and then probably do that. There's a risk of diabetic ketoacidosis, but that's in type 1 diabetes. So I wouldn't start that without talking first with endocrinologists who will have to adjust insulin accordingly. The initial worries about amputation, that it turns out is not true. But to me, the really biggest side effect right now is actually the cost. Okay. The truth is, this is financial diabetes, plenty of food around and no access to it, because it costs in average $600 to $800 with huge help from our pharmacists. And, they're getting better and better approved by insurance company for all this data. But I can tell with a lot of hours spent from our nurses, it takes with usually 3 to 4 weeks to get it approved, maybe in about 30, if we're lucky, 50% of our patients with insurance. If you have no insurance, it's extremely difficult. So that's the main issue here. And I explained to you, if I were to implement this and apply all these drugs on our patient with HFrEF, we can make a 73% impact here. So only basically 3 out of 4, we can save them. And I tell them, you buy at least 6 hours of life out of this. So of course, the current American Heart Association guidelines, they were just updated actually in December. There is a confusing on the American Diabetes Association one. And why are they confusing? Because they tell you, you start with this, then you add that, then you add that. Okay. In the same time, we complain that we don't have our patients at risk who are supposed to be a goal-directed medical therapy. 1 in 4 die or are hospitalized within 30 days, right? So how many patients were starting them in time for this? 1 in 3, not on beta blocker. 2 in 3, not on spironolactone. 1 in half, not on ACE inhibitor. 5 in 6 are not on ARNIs. I would say that's improving now maybe to 1 of 3. And we forget the beta blocker by itself improves your ejection fraction by 7-10% mortality at 3 months. ARNI on top of beta blocker improves ejection fraction by another 5% at 6 months. And really not starting GDMT in the hospital increases risk of not starting GNT by 75% for at least a year. So you'll see me, guys, those who rotate with me. We write already orders for as many as we can and see if they tolerate. We see with the pharmacy, we check the insurance, what they approve, what they don't approve. But this needs to start in a hospital, okay? So the question is, how are we going to implement this to really do better with the GDMT? And you'll say, well, Dr. Butler, who used to be, and together with Dr. Foner, are really the thought leader in the Butler. Dr. Butler is my colleague who used to be here at Emory in our heart failure center. Basically says, step 1, we suggest you should start with all 4 of them, okay? You don't have to get them all the high dose, because 4 at low dose actually working on different mechanisms are more than that. And if you were to look, okay, how am I going to start somebody on all these 4? I mean, they're going to drop the blood pressure, can getting worse. It's actually not as bad. First of all, your SGLT2 inhibitors will do nothing in terms of side effects, except maybe the risk of UTI. You don't even have to check immediate kidney function. There's a little diuretic effect. It's extremely well tolerated, so that shouldn't be a problem. The aldosterone receptor antagonist, you do need to check a kidney function test, like M7, about a week or 2 after you started. Again, acutely doesn't drop the blood pressure unless you have diabetic neuropathy with autonomic insufficiency, where you need the aldo for that. Beta blocker low dose are very well tolerated. ARNI, you need for Entresto, you need a systolic pressure at least 105 or maybe 110. But once you do that, then every 2 weeks you can titrate up to the intermediate dose. And step 3, you can get them up to there 4-6 weeks. I use and I highly encourage, or one day you're going to be the attending. Use the telemed for that. That's perfect design for that. If I get them back in 2 weeks on a video visit, and we talk about, I get them to check their blood pressure and the weights, and then I can titrate safely the drugs. On top of that, of course, you'll need some labs, but patients love that. You establish care, continuity, consistency in the plan. And it sounds like it's really very aggressive, but it's actually not that hard to achieve for the majority of them. Of course, if somebody has advanced heart failure, already kidney disease, if they have an advanced right ventricular dysfunction, they will be very poorly tolerant to ACE inhibitors or beta blockers. So we have to be careful with those. I'm talking about those who otherwise have just an ejection fraction of 25, 30%. Right ventricular function is normal. Only rare hospitalization, admission, and kidney relative preserve with a good blood pressure. Those should be able to tolerate this very easily. And you say, why do we need to rush with this? Here's why. If you start them on ARNI, within 8 weeks, you get mortality or hospitalization benefit. If you start on beta blocker, within 4 weeks, survival curves separate. And I told you 3 months is the ejection fraction improvement. If you start them on aldosterone receptor antagonist, takes about 12 weeks. And you start them on SGLT2 inhibitor, 4 weeks. And that's where they get readmitted. So yes, there is a sense of rush. Let's say, well, there are 4 drugs. I'm a little more conservative. I'm not familiar until you get there. Well, you can do the other way around. Let's start with those that give you the fewer side effects and the maximum impact. And those, what Dr. Packer algorithm says is beta blocker are the best tolerated and the SGLT2 inhibitors. And then you can add the other 2 on step 2 as outpatient, the ARNIs and ACE inhibitors, minority receptor antagonist. Patient comes, you can check a potassium and the kidney, then you're good. This approach, I think, works good, particularly works as well too. Maybe not as strong as the other, but we need to get the doctors and comfortable, but also we need to avoid and improve our clinician inertia to something new that we are not used to really get there. And basically, you got to remember that great science and effective implementation is what saves lives, not just great science. So we're aware of that. Future questions. HFpEF. We still don't have any answer. There's a dapaglifozin trial, which hopefully will show some mortality benefit, not just hospitalization. Having said that, again, 25% reduction in rehospitalization is huge, at least cost-wise, and patient quality of life. I forgot to mention also quality of life in those patients. Heart failure was meaningfully improved in those clinical trials. What about primary prevention? I told you I like to think that I should treat these patients at the insulin resistance level. This will be probably saving lots more if we are to do that. An ounce of prevention is worth a pound of cure. What about renal and cardiovascular prevention independent of diabetes? And what about that versus metformin, which I really think, I hope is not going to show that it's superior to metformin, because I actually think you need both because they work through different mechanisms. So what happens when you excrete 50 to 75 grams of sugar in the urine, which is equivalent of it's not much, it's about 32 ounces of soda, okay? But it's still meaningful, clinical. Your liver actually starts making that glucose. Metformin actually blocks glucose output at the liver. So you need to work on both levels, all right? So I think we'll end up both of them to be necessary, but we'll see. But I'm looking forward to these trials. One is the SGLT2 inhibitor as a standard therapy for type 2 diabetes, the SMARTest trial, and the other one is the DELIVER trial, which is dapaglifozin in heart failure with preserved ejection fraction. Basically, in summary, the contribution of this SGLT2 inhibitors is that they have a great robust effect on improving heart failure related mortality, mostly due to heart failure admission. They have decent effect on MACE outcomes and new strokes or heart attacks. The lower the GFR, the greatest benefit, and even including the heart failure hospitalization. The sooner you start, the better the baseline GFR, the more potent is the outcome. And you can use that now, SGLT2 inhibitors, independent of whether a patient has diabetes or not, at least in HFrEF. And I'm going to add this here to this slide that's adapted from Dr. Zernick and Braunbach review, saying that probably the benefits are likely related not just to the inhibition of renal SGLT2, but also sodium hydrogen exchanger in the heart, kidney, and liver. And I could just leave you like that, and I gave you everything you need to know about drugs. Those who work with me knows that I prefer to work with lifestyle. I really think that we get to this stage of having minimal impact in our cardiovascular outcomes or patients, mostly because we fail of changing the lifestyle of the patient. Basically, if you were to just keep eating what you're eating that got you into this, I'm going to give you this drug, so you keep doing what you're doing. But if we were to actually change those risk factors, meaningful, This is what happens. This is the courage trial. Any of you knows what courage trial was? It was a very courageous trial. Basically, patients who had 2 or 3 vessel coronary disease, who otherwise will undergo PCI, were randomized to PCI versus just medical therapy and lifestyle changes. Okay, and you know the outcome? No difference. Follow up to 10 years, no difference. And then they looked. They published recently this paper 2 years ago in JACC, and it was fascinating. They look, okay, from those who survived with diabetes, who did better? Guess what? All you need to do is to control one of these risk factors meaningful. That means if you can get your patient to quit smoking, increase their exercise to about 30 minutes a day, and follow consistently some form of healthy diet. And ideally, if you can get their hemoglobin A1C also control, then each of those is 90% reduction in mortality. We're talking about 90% mortality, absolute mortality. We're not talking about cumulative endpoints of heart failure in this. And only one risk factor, if you change it 10 years later, has this impact. So yeah, if you change the lifestyle, you're way more potent. Or you can try to prevent heart failure by just switching from a southern diet, which everybody knows what southern diet, frying saturated fat, meat-based diet with lots of added sugar, particularly fructose, and you follow them. You know, we live here in the stroke belt, and you compare it to people who were plant-based. Actually, the ones who are plant-based have a 4-fold lower risk of developing heart failure, where the ones who are southern diet, they have 8 years later, 72% risk increase. So I'm going to conclude by telling you, I pretty much changed this a little bit. So I said, a wise doctor puts a grain of sugar in everything they say to their patient. And it takes with a grain of salt everything the patient says to them. All right. But the truth, take home message here is that this is truly a tale about how our body processes together sodium and glucose, in particular fructose. And everything I just told you needs to be taken with a grain of salt, but also sugar. All right, thank you. I'll be happy to take any questions. Go ahead. Yes.
First, thank you so much. This is really phenomenal. I feel like in my experience, the number one reason I see that SGLT2 doesn't get prescribed when we're considering it, besides all the financial problems about kidney function and the GFR being too low or an SGLT2.
Yeah.
It also seems like what you're saying, though, is that SGLT2 is demonstrating its most efficacy in patients who have the lowest renal function.
That's correct.
And so I'm just interested to hear your thoughts on our criteria for choosing not to start an SGLT2.
Right. So it's a very legit question. Right now, what appears to be right now the biggest hurdle in starting somebody with SGLT2 inhibitor is actually advanced kidney disease, and that makes us reluctant. Well, according to the trials, we actually empaglifozin in the Emperor Preserve trial was used with the GFR as low as 20%. So we actually can start we have at least one agent, Jardiance, empaglifozin, 10 milligrams a day with a GFR 20% or higher. So that pretty much, short of you needing dialysis, is pretty good. All right. And in terms of dapaglifozin and the canaglifozin, you need a GFR at least 30%. Okay. And I say, as long as you have that GFR at one point, you feel like it's quasi-stable, at least that level, probably you can start to consider placing them on that. But it's a very good question. Yeah. Any other question? Go ahead. Yeah. For that, in dapaglifozin, the entry criteria was the GFR over 30. That's correct. So, but we're going to have, I'm sorry, but you're right. Actually, I cannot talk about speak over the top of my head for the equivalent, because we have the equivalent Emperor reduced, with empaglifozin. Well, I know it's 10 milligram dose. I cannot tell you 100% if it was 20 or 33. And I think the reason why they so I don't know 100% for that, but it's probably okay to use it even for that. It's okay. The reason is we have the Credence trial that showed that GFR over 20% you can include it. So it came out, those are pure kidney outcome trial, okay, by nephrologists. So these are, now with dapaglifozin, you have to stick with the 30%, although it's going to be interesting once we have the DAPA equivalent heart failure preserve trial, see maybe they change the inclusion criteria there. I really don't know at this point. Yeah.
So it seems like
So good question. So shall we start to diagnose insulin resistance? Actually, obvious, there is right now, there is a way how you can do that now. You measure not just the fasting glucose, but also fasting insulin level. Also, you can send them for a glucose tolerance test, particularly if you need to convince them, man, as far as I'm concerned, your heart and your kidneys and your liver are already seeing diabetes from insulin resistance. So you can start with that. Obvious, the glucose tolerance test, although it's the gold standard, will be very difficult to just apply on large scale. But I think a baseline insulin that's elevated, and you have also a lipid profile that's consistent with triglycerides going up, HDL going down, and LDL going up. I think that pretty much with somebody who's already overweight, that pretty much puts you into that category there, at least statistically speaking. And I personally think metformin actually has been used for that. We actually know in those, right, it's approved. We're supposed to offer it to our patients. You get about 5 to 10% weight reduction initially, which in long term may not happen. You have to be careful with metformin used on large scale because also it's associated with about 80% patient will have vitamin B12 malabsorption. So you'll have to supplement with B12, but it's a great drug to start with. Unfortunately, in order to upgrade that to SGLT2 inhibitors, that's why we need the trials. But I submitted you there that I am a bit frustrated that our diabetologists are not changing their mentality, how we should approach as physicians this condition, and probably why we have failed. Because I really think we need, whether it's drug or lifestyle changes, we need to come up with more meaningful reproducible lifestyle changes, and also possible drugs, if we can afford them, to really attack that early stage of insulin resistance. And that's where we're missing the boat. I agree with you. Yeah. Good. Excellent. All right.